Councilmember Alexander, other councilpersons and colleagues. My name is Guy Weston. I'm the Executive Director of DC Care Consortium, which is the HIV/AIDS service organization in Ward 4. My experience related to health disparities go back to the period of the 1985 HHS Secretary's Report on Black and Minority Health, and I go back that far because it's interesting to look at how things have changed over the last 30 years, and I would like to briefly share with you some observations from initiatives in various jurisdictions, including the District of Columbia, over the last 3 decades that either facilitate or complicate efforts to promote health equity among populations that have disproportionate burdens of adverse health conditions. And I would, given our time limit, like to focus solely on the first duty of the proposed commission, which is examining health disparities. The proposed legislation calls for comprehensive recommendations which examine health disparities in each ward of the district. That sounds like a very reasonable proposition, but in fact, it frequently becomes quite complicated. First and foremost, we do not have consistent data collection by ward across the multitude of databases that will be utilized for such an endeavor. Where data do exist, it's not uncommon to use zip code as a proxy for ward. This is not a reliable method as it produces errors in about 30% of cases. If we want to examine health outcomes by ward, we first need a reliable system to collect health data by ward. There are also other data collection issues, and there are numerous, but one I would call to your attention is reliable data collection about Latino and Hispanic populations, which are often misclassified. Many times we don't know the true health outcomes of Latino populations, so they're classified as either black or white, depending on what they look like, instead of how they personally identify. And that's personally driven by federal standards for data collection, which many providers don't understand. Secondly, health disparities are largely a social phenomenon. Over the last decade or so, social determinants of health have become a popular buzzword. Nevertheless, we have a public health workforce and mentality about health promotion which relies largely on training in the biological and sciences and biostatistics. If we want to understand a social phenomenon, we need to engage medical sociologists, medical anthropologists, and people who understand health from a social perspective. To use my field of HIV/AIDS as an example, when we ask questions like why African American women account for 50% of HIV/AIDS cases when they only account for 51% of the district population, or when African Americans overall account for 50% of the population, rarely do we get a straight answer. If we can't get a straight answer to that question, we can't expect a reasonable strategy to be implemented to address the problem. In brief, we know that HIV/AIDS rates should be understood in the larger context of the inferior health status of African American population as a whole. We know that the leading causes of death in the United States are heart disease, cancer, chronic lower respiratory diseases, stroke, Alzheimer's disease, and diabetes. African Americans are disproportionately affected by all of these diseases. So maybe the disproportionate incidence of HIV infection among African American see condom messages or condom campaigns, and more about addressing the root causes of why African American populations overall have poor health outcomes. Thirdly, we need to better understand how social determinants such as geography, social networks, stigma, poverty, insurance status, traditional gender roles, religious beliefs, as well as racism and homophobia, whether perceived or real, impact on health behaviors and utilization of health services. Many of these factors fall outside the sphere of health programs, but they still are influential in health outcomes, so we need to engage other sectors to address health outcomes. I wanted to make a few other comments that weren't part of my written record, one of which was that we have to have meaningful metrics to measure progress and promote accountability. Many times we have metrics like reduce the incidence of a disease by 50% in 3 years. That's never going to happen. So people don't even take it seriously, and it's not useful for the purpose of monitoring accountability. Sometimes I've worked in government systems where the indicators, the performance indicators, impact on a manager's performance evaluation or on the agency's performance evaluation. So they're not taken seriously, or people are afraid to report actual outcomes because of how they may impact on them personally as managers. So we have to find ways to measure outcomes without those political interferences. I wanted to comment also on whether we have a single disease approach. I think that's not wise. It's not about a disease, it's about health behaviors, health beliefs, health services, utilization of health services, healthcare infrastructure, cultural competence, and provider relationships with underserved communities. If we want to address underserved populations as a whole and their disparities, it's not about a particular germ or health condition, it's about the larger issues that we have to address. Lastly, I want to say that we would be remiss if we did not include individual behavior in defining the problem. At the same time, we can't focus solely on individual behavior because behavior does not occur in a vacuum, and there are other factors besides behavior that affect outcomes. Finally, I thank you for this opportunity to share my perspectives with you, and I look forward to the passage of this bill and all the important work that will follow.
Thank you, Mr. Weston, and that's what these hearings are about, to hear the different views from the witnesses who testify. And I am compelled by some of your statements or views in your testimony. I do appreciate them. What would be a reliable system, first off, to collect the data by ward? And what's happening now, because I do know we do have some statistics by ward, like we know wards 5, 7, and 8 may have higher mortality rates and higher instances of some cancers and diabetes and hypertension. So what data is being collected now, and what do you think needs to be improved?
Well, I was a government employee 10 years ago, so part of my experience is historical, but even as a provider that's funded by the district government, I know, for example, that there needs to be a system where you can type in an address and a ward will be assigned. It's not up to asking somebody what ward they live in. It's not up to look at that they live in 2005, that must be Ward 2. In that case, that works, but in many cases, it doesn't work. So we don't have a common understanding or a common practice across all agencies to collect the information. The fact that you have a report that says you have a number of 90 associated with a particular ward you don't know how anybody arrived at that 90. It could be that somebody said, oh, they did it by zip code, or that they asked the person where they live in, or if somebody made an observation, but there is no system-wide approach to collecting data by ward.
So are you familiar with the Department of Health's Community Needs Assessment or Community Health Assessment?
As a provider, I am, yes.
So how do you know, right offhand, how these statistics were
I wouldn't feel comfortable commenting in public on that because it wouldn't be fair to the people who actually did the work who I have not communicated with. However, they have to
that's what I'm asking you.
But they have to rely on, it's not the people themselves at the health department that make those determinations necessarily. They have to rely on providers, they have to rely on self-report, they have to rely on information coming from a lot of different places. So it has to be that where the data are collected, there's a mechanism to associate an address with a ward. Anything else is suspect.
Thank you. You also mentioned that it may be more like, what are the additional questions? You use the example of HIV/AIDS with African American women, and you're saying that we need to ask deeper questions as to why it's a higher percentage when the overall African American rate is lower. Why would the women be so much higher in that particular subgroup? So what, aside from a condom campaign, would you recommend when you say find the root causes? These are some of the things you think the commission
Sure. Okay, so if we're talking about HIV/AIDS and women, we have to think about things like traditional gender roles. We have to think about things like if we have a patriarchal society engaging men, because ultimately men are going to have impact on women's health outcomes. We have to think about cultures where women value their families, their husbands, and their children over themselves. Right. So it's not about giving information. HIV is a disease that can cause you illness. It's about teaching women to value themselves and maybe how to juggle multiple responsibilities to not put off HIV because it takes many years before it becomes a serious problem. So it's a matter of dealing with the reasons why people put off health care, or dealing with the reasons why people don't believe that HIV is a threat. People don't feel vulnerable to HIV. That's not about knowing HIV is a disease that can be fatal. It's about making people feel vulnerable, and that has nothing to do with information. It's about convincing people that it's relevant to them.
And you mentioned social determinants, and that is a buzzword. I think it is important. I think there are social factors that definitely result in better healthcare outcomes. But could you explain further what you mean we need a better understanding of
I think that we tend to look at disease in terms of germs, in terms of patients, in terms of individual actions of people, and we don't understand, for example, that even if The health center where I go in my neighborhood is not homophobic and I'm a gay man. I'm afraid they're homophobic, so I don't go. That has nothing to do with whether they really are or not. Or I'm afraid that they're racist because they're white and I'm black. It may be that they're racist. It may be that I think they're racist. It may be that their particular way of communicating is not comfortable to me. So how do you teach providers to be culturally competent? How do you teach providers to value the patient's perspective? Another thing that happens very often, there's a belief sometimes that our providers tell us things and we can't ask questions. People have to be empowered to ask questions.
That's interesting that you say that, and I could say on the flip side, a lot of persons I talk to think for some reason if a provider accepts Medicaid and they have commercial insurance, they don't want to go to the same doctor who is providing treatment to Medicaid patients for thinking that they're not going to get the best treatment. And I never understood that as working for a Medicaid HMO, and it was really unusual to me that we actually went to the same providers that our customers went to. So it didn't connect with me, but I can understand why people do have those worries, and it may prevent them from going to a particular doctor. So that is good to look at other things that we need to talk about, what's preventing people from getting the health care that they need. You also mentioned you're worried about when it comes to accurate reporting, that people's jobs are on the line. So if, say for example,
I know.
Yeah, what you added to it. So say for example, if DOH reported that, cancer has doubled in 2014, but yet we allocated millions of dollars towards reducing cancer, you think that they would be afraid to report that it doubled because we've allocated funding towards that initiative? So you think that they may skew
I would just speak in very general terms that I've been in many discussions where people are concerned about performance indicators and their impact on performance evaluations, or people want to define performance indicators in a way that will highlight progress and not necessarily emphasize failure. But the larger issue is that many health indicators fall outside the scope of, you can't, for example, say that you allocated $1 million this year and you expect HIV to go next year, or that you have a needle exchange program in Ward 2 in 2014 and you expect to see a reduced incidence of HIV. And so people try to connect the dots closer than they can be connected. So part of it is being more realistic about what you can attribute to a particular behavior.
It could be that we may need to put more resources
right
in that initiative, and that's why we're not getting the results.
Or it could be that you need to wait 5 years before you can see the impact of an action that took place today.
Exactly. So do you believe that the reporting aspect of anything should not rely on the government per se, or should it be an independent?
Well, I think the government is the only entity that's in a position to coordinate and monitor at a system-wide level. I just think that we have to take all these factors into account when we determine what our indicators are and make people feel comfortable reporting what the true outcomes are and not feel like they should be held accountable for something that's not reasonable to hold them accountable for because it's too soon to measure the outcome of their efforts.
Right. Well, I would definitely think they're not, because we rely on them for the statistics. So I hope that we can, I hope that we can resolve that we would get accurate reporting. And lastly, you said the no single, and I've heard this with earlier testimony, no single disease approach should be, and I thought that may be a good idea because we hear so much about the cancer, the HIV/AIDS, diabetes. We're hearing that those stand out so greatly in the district with growing numbers. So I'm wondering, when you say we should not take that, and I understand your position on that, it should be an overall approach and not a single.
Well, I think certainly if there's a particular issue that's overwhelming or outstanding at a particular point in time, it certainly warrants action. But I also think that there are commonalities across all of these different health conditions, that by addressing why people don't utilize healthcare, by addressing why providers aren't culturally competent, by progressing why the community has health beliefs that are contrary to what they need to do for themselves, you would get more bang for your buck rather than just focusing on one disease.
Thank you. Councilmember Grasso?
I appreciate your testimony. I don't have any more questions, but thank you very much for adding your expertise on this.
Thank you.